Good morning, everyone. Welcome to our Partnering Provider Transformation Plans webinar for today. We've got a great group of people who have signed up. Because there's so many people on the call, we're going to keep the room muted, but if you have questions as we move along, Kim is going to be tracking those and will stop us so that we can answer anything along the way. And then we have allotted quite a bit of time at the end of the webinar to answer specific questions, and we'll unmute the floor and let everyone ask away. So with that, I think we're going to go ahead and get started here. Today's webinar, we want to do a number of things to really level set the next phase of work in our transformation implementation planning. So first we'll talk a little bit about where we're at in the process, how much money has been earned, and the future earning potential for the region. We want to spend a little bit of time talking about how we conducted each of the reviews of your provider plans, what we saw, and then give you an overview of the learning cohort model that the board approved last week. And then we'll walk through what you can expect in the feedback sessions that we are currently scheduling and some next steps to try and be as clear as we possibly can over the next few months of work ahead of us. And then, like I said, we will leave some time for questions, and hopefully I will have answers for you. I want to just spend a couple of minutes thinking about where we have been over the last getting close to 2 years of Medicaid transformation work. I want to remind everyone that in January of 2017, the state agreed to the terms and conditions with CMS for the 1115 waiver, which would allow about $1.2 billion to be earned over a 5-year period for the state to transform the Medicaid delivery system. That set in motion a number of sort of foundational planning efforts that BHT, sort of on behalf of the ACH, needed to accomplish. So in quarters 2 of 17 and 18, we moved through a number of planning processes that included both some governance work to ensure that there was an appropriate level of provider and community feedback, as well as ensuring that the board had a diverse set of recommendations coming to them via these technical councils. The other piece that was critically important in order for us to earn both our Phase 1 and Phase 2 certification money was to demonstrate active engagement across both traditional Medicaid providers as well as non-traditional Medicaid providers. Additionally, we needed to develop a robust set of communication and feedback opportunities for the region. We were successful in meeting all of the healthcare authorities' criteria to earn a full $6 million, deeming us certified as an ACH. Additionally, in late 2017, the county commissioners from around the region agreed to be a mid-adopter for fully integrated managed care, which earned the region $8.3 million. So if you think about 2017, it was really about getting those foundational elements in place so that as we moved into 2018, we actually started building our implementation plans. So you can see that we were successful in earning $11.3 million. That was really based on both the governance and planning structure that we put in place, but this idea of county-based collaboratives that were comprised of not just the healthcare delivery system, but really the entire community health system that included our social determinant of health partners, the criminal justice system, the public health department, certainly our healthcare friends, our tribal partners, et cetera. So you'll remember we spent a lot of time in the first part of 18 really getting that both structure in place and seeking support from our partners to participate. This spring, we had 80 partnering providers sign MOUs to participate in transformation, and that resulted in 6 county collaboratives submitting their collaborative plans with the while we were thinking about this, a sort of minimum number of partners, with all of the partners that we had expected to participate signing on to the collaborative plans. So that really gave us sort of this foundational structure to be able to think about the Medicaid transformation as it related to our 4 project areas, plus some other pieces that both the board and our technical councils felt were important. So this summer, we had 45 primary care and behavioral health providers submit their transformation implementation plans that included very specific elements of their efforts to do bidirectional integration, chronic disease management, and opioids. We've continued to sort of pull out community-based care coordination to really link that work specifically to the collaborative. So while there was some level of commentary and planning related to that, the 3 target areas were really the clinical transformation portion of that. The other piece that I would just remind you of is on Saturday, BHT submitted our regional transformation implementation plan. So that was the compilation of our 6 collaborative plans, plus was informed by the primary care and behavioral health providers' submitted transformation plans. The document we submitted to the Healthcare Authority included very specific milestones, which will be what drives our earnings of the paper reporting milestones as we move into years 3, 4, and 5. And yesterday afternoon, we were notified that we had earned the full $8.9 million for submission of our semi-annual report. So we've now officially earned 50% of our year 2 funds. The balance of those dollars we expect to earn late this year as it relates to the implementation plan that we submitted on Saturday. We wanted to spend just a moment here acknowledging that we are about to transition from the paper reporting, where there was a lot more just check off boxes for us to earn our full amount, and are transitioning into the paper performance period. So year 3 of the waiver is 25% of our dollars are at risk for performance. So you will start to see a higher level of accountability in both our reporting and our planning as it relates to meeting these metrics. And so we're thinking about 2019 as really, this is when implementation begins and paper performance, and really starting to shift that thinking for all of us in how we get ready for that environment. I want to note, and I'm not going to walk through each one of these years, that because our dollars are now being tied to paper performance, the period with which we will actually have access for those dollars will be over a long period of time. So what we earn in 2019 will not actually be available to us until 2021. So there's a lag period here in doing this, which means that some of our paper performance of the technical year 5 of the waiver won't actually be in the board's hands to distribute until 2023. So that $1.2 billion that we often talked about, you can see it starting to get smaller and smaller year over year. The other thing I would highlight is there is an increasing pay for performance based on meeting VBP milestones. And so, as you know, we're moving to a higher percentage of Medicaid dollars being in a value-based payment contract by 2021, where 90% of all of our Medicaid dollars need to be in a VBP contract. So this was something to note, and I hope you'll see that thread pulling through both our feedback and our future funding models. I think I'll pause there, look at Kim, and see if there are any questions. She's shaking her head, so I must have just nailed my clear description of where we're going. That brings us to what I think everybody is super interested in knowing, which is what happened to my plan and where do I go from here? So first, I want to talk about how we conducted the review of each of the plans. They were evaluated by multiple reviewers. So we have had health management associates and the core team, which is our data and analytic partner, under contract for the last year. So each of the plans were reviewed by at least 2 members of the HMA and core team, including every plan had a clinician review. We think that's really an important point to note, that a lot of this feedback is not just organizational, but is really on the clinical transformation side of things. Additionally, 2 members of the BHT staff also reviewed every plan. And finally, a number of you, looking down the list here, also participated in our volunteer review panel. And those volunteers came from membership of each of our technical councils. So rest assured, this was not a one person looked at your plan and decided where you fit. It was a very thorough feedback with a couple long day sessions of trying to come to a solid agreement on the set of feedback that we needed to conduct. The next piece that we want to really highlight is that this was the plans that we reviewed were reviewed with an eye towards being ready to contract for transformation, and that we would fully acknowledge we know a lot more now about what we want to see in plans than maybe in March or April when we were developing the template, and that some of the plans we could see places where we knew there were other activities happening, but they weren't showing up. And in other plans, it was really clear the very specific steps that were necessary. So I'll get into a little bit more feedback, but I think at a really important grounding principle here, the reviews were conducted with the idea providers would be ready to contract in 2019 for specific transformation activities. As we started this process, we spent some time with our board really being clear about the principles that we were trying to meet with our regional implementation plan. And so I just want to highlight these elements because I think you'll see them being woven into the feedback as we move forward. The first is the board's charge to the BHT staff that we hit our performance measures so that we earn 100% of every dollar available to the region. And they wanted to make sure that we were very clear that the performance measures would be important to hit so that we left no money on the table. The second item was because of the clunkiness, I would say, of the project toolkit, they wanted to make sure that these plans were really transformative, not just let's teach to the test or let's teach to those performance measures, and that we weren't trying to just hit the measures. We are trying to use this as an investment in a transformed system. Next is that it will be important to push and reward our larger providers to transform without leaving behind any of our small rural partners. And I think you can really see that commitment in our funds flow allocation in year one of how we have invested in many of our partners across the regions. I think it is worth noting that we are one of the larger ACHs in terms of total partners engaged, and we are one of just a few ACHs that aren't starting to shrink the number of providers that they are contracting with. So it's been a really important principle that we not just focus on volume, but also on the overall delivery system. The board also highlighted the importance of looking for shared training, technical assistance where it made sense, really wanting to ensure that our investments were as high impact and as efficient as possible. And so one of the examples we've been using is if every entity is going to need some change management training for providers, having 48 different partners going about doing that is not as administratively efficient as it could be if we were organizing across the region. So sort of keeping that principle in mind as we both reviewed and suggested a next set of steps. The final couple pieces here, I think, are really the critical part of our process and what we were trying to do with these transformation plans. We recognized they were a huge lift and that it was really important to the board that we were allowing individual providers the choice and independence to really take the elements of our requirements or the project toolkit and align them with business strategy. And if it didn't align, that we weren't going to be able to incent enough investment to make anyone do anything. So we've got to find that right balance of how we're creating a regionally cohesive system while also recognizing that each of your organizations has an overall business strategy you're trying to accomplish. And then the final piece is the foundational capacity that we have an opportunity to invest in that will be critical to our long-term success. And so we've been referring to that as really our foundational capacity. And I think as we were reviewing the plans, this became even clearer that focusing some element of both our intentionality and our investment will be important. So the first is really this idea around leadership, change management, and cultural shift. Probably the most important feedback we have gotten both from our consultants and from all of the best practices sharing that we have done with other 1115 waiver states and certainly with our friends from Oregon is how important this piece of the work is, and that without that in place, it is hard to see a very transformed system. Thinking about quality improvement capacity, there was a lot of focus in all of our plans on data. When we think about QI, it's going to be important to not just think that the answer is having more data, but really how are we applying that data, which then gets into our previous point around the culture shifting. Patient engagement in the overall transformation activities continues to be an area we think that there is growth and opportunity across all of our providers. Community engagement, we saw a nice recognition of community-based organization or social determinant of health partnerships starting to form as we move into true value-based payment modeling for things, this is going to be increasingly important. Ability to capture and use data, I think we saw lots of both identified need to do that and awareness that more investment needs to be able to do or needs to occur in that way. Sharing information between providers, and then the final foundational capacity is really just the support for billing, coding, and financial operations and how those really merge together with systems of care. I'm going to walk through this slide and then we'll pause and see if there are any additional questions so far. We have made a deep commitment to try and push dollars out to our partners as quick as possible. So this just gives you an overview of the funds earned year to date for each of the county collaboratives. You can see the number of partners that are in those collaboratives and the settings that they represent. This totals up to about $6 million that should literally be in your bank account. I will do a quick commercial here. If you are not receiving your funds earned so far, there is likely a issue in the portal with your account being active, and Jenny stands ready to help answer any of those questions. I think we've just got a few folks that there's still some glitches. And once you get that done for this first time, then your money will flow in a little easier way. We would acknowledge it is not the smoothest system that has ever existed, but it does allow a level of accountability to both the state and to the community in how our dollars are being allocated. I think that I'll make one other point and then I'll pause to see if there are any questions. We also just wanted to acknowledge the amount of work our primary care and behavioral health providers have been asked to do and our really sincere intent to try and make investments in those partners to ensure they have the capacity to do it. So to date, our primary care providers have earned between $19,000 and $129,000, and you can see there how those dollars allocate. And our behavioral health providers have earned between $79,000 and $159,000 year to date, based on both their eligibility to earn fully integrated managed care incentive dollars as well as our project funds. There are some additional dollars available that we expect all of our behavioral health providers to be able to earn by the end of the year, of another $50,000, which we know has been a really important cash investment for many of our partners to be ready to bill come January 1, 2019. So I think with that, I'll look over to Kim and see if there are any questions coming forth.
I have no questions in the chat box.
Okay. I find it hard to believe nobody has any questions, but I will keep moving us forward. A little bit more context setting for us. The first is we received 45 total partnering provider organizations plans. It represented 50 total plans because we have a few folks who are both primary care and behavioral health. But I think that's just an important recognition there of how many partners that we're working on. And then the other piece that we thought was interesting was how many beneficiaries our providers were serving. So you can see bulk of our region is served by our 4 largest providers, and then not too many folks in the 25 to 10,000 beneficiaries, and then a number of partners that are really small, which is reflective of both the rural nature of part of our region as well as the diversity of behavioral health providers that we have. So moving on to the section of what plans were reviewed for. I want to make a couple of really important points here. Again, we were looking for, were the plans complete? Were there any questions that were left unaddressed, and were there significant gaps? It was important that the plans were reflective of the models that were listed in the Medicaid Transformation Toolkit and our regional goals. So you'll remember, not only did we have the models that were reflected in the toolkit, our technical councils had also worked through some added requirements that helped meet our BHT regional goals. We were looking for clarity, and I think the clarity we saw in some of the plans around the specific activities and the clear aim statements. Others, it was a little bit murkier for us to try and get that clarity. And then the final piece that we looked for was really, is the provider demonstrating a capacity for quality improvement and project oversight? So these four areas were not a number score as much as we were looking for specific elements to be reflected in each of the plans. And what we saw was that there was a vast variation in the clarity and concreteness for each of our providers. We found that often the bidirectional plans were more clearly articulated than our chronic disease, and a number of our partners had really strong opioid plans that we were really pleased to see. Large variation in quality improvement, change management, and leadership capacity. We believe that part of that is just related to what was in the plan versus what wasn't in the plan. And so in our feedback sessions, that's going to be an area of exploration. Generally, across most of our plans, patient and community engagement, as well as the lens of equity, were not well developed. We saw deep commitments to equity and intent, but not as actionable as we think will be necessary in order for us to meet both our vision of transformation and some of the concrete nature of how the region will earn dollars. Most of the plans didn't make a strong connection to the pay-for-performance measures, which we have done a lot of internal dialoguing about, and maybe because of how the template was set up, but one of the things we're going to want to make sure is part of all of our contracts is that connection to the pay-for-performance measures. And a whole lot of focus on EHR and IT capacity. And I think our consultants very wisely sort of warned us that while that is an important capacity to develop, it is not a silver bullet, and that part of what investing in EHR and IT capacity is really the improved business and clinical processes that go with that. And so we want to make sure that quality improvement process is very actively tied to EHR and IT capacity. So with that, everyone should have received an email from a BHT staffer letting you know which of our two broad categories you fit into. Ready, which we're referring to as our January cohort, and needs further development, which we're referring to as our August cohort. So in the January cohort, what we saw is that most of those partners had addressed all of the elements in their plans. One of the things that we saw in those plans was really clearly articulated aim statements and specific activities to move forward. There's a range of ready in all of those plans. So every provider in the ready section will have some additional planning work to do in order to be ready to contract in January of 2019. And we'll talk a little bit more about what that looks like. So I want to just make sure that nobody is walking away feeling like this group totally nailed it and this group didn't. There was just a range of readiness that we saw. The second group is really this needs further development. And so we saw that in that initial set of criteria, half or less than half really lacked specifics that would be necessary in order for us to be ready to contract. We think it is incredibly important to note that needing further development is incredibly appropriate for the amount of change that many of our providers are undergoing at this point, and that if you go back to the board's initial set of principles, one was that we didn't leave anybody behind. And so these two broad categories are really reflective of our intent that we are trying to ensure that the system, and that is the providers in the system, are really ready to move through transformation in a really effective way. So the board last week approved our next step approach, which is for the provider plans that are ready, and we are referring to them as the January cohort. They will have until January 15th to refine and finalize their plans so that those plans can be attached to the contract that they will be asked to sign to earn the next set of money. We're going to provide a very simple feedback template with clear instructions of what needs to be in that plan, as well as we will walk through that in our individual feedback sessions with each individual provider. There is not a sort of set amount of work that is required. So some of our providers are going to have more work than others. We're also inviting the January cohort to participate in some of the learning activities we have planned for 2019. But in essence, this group will be ready to contract with BHT and be on the hook for the 25% of our pay-for-performance dollars that we will be earning at that point. For the plans that need more development, we will be requiring participation in our learning cohort, and we're calling that the August cohort. And this learning cohort will work with individual partners on a month-by-month basis to ensure that their plans meet the foundational capacity to be ready to contract in Q3 of 2019. We expect that the August cohort will be paid for some of their participation. So you will start to see a separating out of pay for performance versus pay for participation modeling moving forward, though I do want to say we have not established what those amounts are, and I'll talk about those in our next steps in a moment or two. Are there any questions?
We do have some questions.
Kim is signaling to me. That was not as sly as maybe it sounded.
So we have one question wondering if this recording and webinar will be available on the collaborative webpage, and yes, it will. We will post both this recording and the slide deck onto the collaborative workspace by tomorrow morning. Next question is, if you are part of the August cohort, when would the first meeting be, and approximately how long would those meetings last? And I think what we're looking at is the August cohort wouldn't really get up and running until January of next year, and in order to really get the most bang for our buck out of our time together, we're looking at anywhere between 3 and 4 hour chunks of time every month to spend together. Is that correct, Allison?
Yes, and I've got a slide that'll talk a little bit more specifically about that, but it will be a monthly commitment that will range from some in-person and some webinar work with a key set of milestones required each month that ensure that by August 1, 2019, that the provider is ready to contract.
Next question is, what does it mean to be reimbursed for participation in the August cohort?
We would expect that if you have actively participated and met the milestone, that there will be a payment attached to that.
Great. Next question, could you, for the room, because we have some new people to this process, could you kind of define the difference between pay for performance and pay for reporting?
Sure. So we have thought about pay for reporting as you just tell us you have accomplished something. So the submission of an implementation plan or one of our assessments or an MOU is a pay for reporting milestone being met. Pay for performance really focuses on the outcomes. And so things like reducing jail recidivism or reducing ER utilization or increasing asthma medication compliance would be in our pay for performance metrics.
Thank you. And we have one last question here. Will the region's initial pay for performance just be based on the providers participating in the January cohort, or is the state still going to analyze total Medicaid encounter data for the whole BHT region, aka all the providers?
That's a great question. So we will earn dollars based on the entire performance of the region. And I think what I would expect, and again, we've not approved our funds flow, but I would expect that the January cohort will be able to earn pay for performance incentive dollars as it relates to those performance metrics. But again, I can't stress we have not made a governing decision on that. That is still under development, and we'll go through our technical councils, including both our Provider Champions Council as well as our Waiver Finance Council.
Okay.
Excellent. Okay, those were great questions. I want to just walk through what you can expect from the feedback process. So you should have received an email last week from BHT telling you which cohort you have been assigned to and asking to schedule a feedback call that will include some combination of the BHT and HMA team. In these feedback calls, you can expect to receive very specific feedback on the strengths and weaknesses or gaps in your plans so that it's very clear what work needs to be done in order to be ready to contract with us. We also will provide our explanation of why you were assigned to either the January or August cohort, and then again, being just really clear about the additional information that will be needed to contract. We see these being very much a conversation. I know it is incredibly difficult to capture all of the work that a provider group is putting forth in a single sort of template that we have designed, and we've designed that template with an eye towards what we need to report to the state. So we want to really use this to have some back and forth around the elements that we think will be necessary and what was in the plans. We thought it was important to say that if you have been assigned to an August cohort and you think you really are ready to contract, that you would be able to sort of make the case to move up to the January cohort by submitting the required additional information in that way. Again, we really can't stress enough that the August cohort is not designed to be a punishment, as much as a commitment to make investments to ensure that every one of our provider has the ability to be successful in both the earning of our transformation dollars, but more importantly, in being ready for value-based payments and value-based care and the ongoing pressure that the systems are feeling to really look at population-level health improvement. I'm going to walk through just a little bit deeper set of expectations for each of the cohorts. I think this will be clear in our one-on-one sessions, but just to kind of give you a sense of what is ahead. So again, for the January folks, we will provide a template that will clearly define the questions that need to be answered, and things that you could expect could be asked for further clarity would be how your behavioral health primary care integration really intersects with chronic disease and your opioid work. How is that really working in a collaborative way? How the plan that you have submitted really aligns with both the HCA's goals as well as the BHT goals, the clarity in aim statements for each of the project areas, some discussion on the feasibility of the budget. And I'm going to take a moment here to say what I believe will become an ongoing mantra for us, which is we are not funding your individual budgets. The budgets were really designed for us to see where there were commonality of expenses that were likely to be spent to support provider and clinical transformation that would make more sense to be thinking about regional infrastructure investment. The dollars that you are earning are really performance-based, and once you have earned the dollars, so the $4,000 you earned for the MOU or the $15,000 you earned for completing an assessment, is up to you to fund the activities that you deem necessary to move through transformation. So the budget portion of this work was really to ensure there was a depth of plan for the needed capacity and to look for commonalities across plans that we might choose to invest in through our regional infrastructure dollars. Additionally, I think we will be looking for further clarity on capacity to implement. I think we've got some very specific questions for our January cohort folks around a little bit of chicken and the egg kind of thing. And then the final piece that I would expect every January cohort member to need to spend some additional time on is really the set of milestones. And the milestones that will be in your contract will be a combination of the BHT regional milestones as well as the ones that you have identified would be necessary to move towards achievement of your implementation plan. And again, we expect that these templates would be resubmitted by January 15th. They could be done sooner, which would earn you the additional implementation dollars that the board has allocated and would allow us to start moving towards contracting. Our goal is that by the end of Q1 2019, our January cohort partners would all have contracts in place. So I'm going to pause there and see if there are any questions that have come forth.
There are some questions that have come forth. One question is, can we come to your office for the feedback session rather than on the phone? And I think we can absolutely say yes, we would love to have you in person. And if any of you are panicking because you haven't received an email, those emails went to the lead that was listed in your Partnering Provider Transformation Plan. We just sent it to that one person. So they would have that information, and if you want it in person, just please let us know that in your reply. The next question is, how will you determine the amount for pay for performance contracts?
That is a great question, and as soon as I walk through the August cohort expectations, we'll talk about next steps in that. This is a very engaged process, so there'll be lots of opportunity for feedback from partners as we're developing the model.
Great. And the last question we have in there is, where on the BHT website are the BHT and HCA's goals listed? And I will put this web address in there, but we have a web page set up specifically for our collaborative members. It's betterhealthtogether.org/collaboratives. And on the sidebar of that page, on the right sidebar, there's a heading called Documents and Resources. And about halfway down, there's a file called P4P Measures, which is all the measures that we have so far from the HCA. I don't know that we have BHT ones published yet. Correct me if I'm wrong there, Alice.
We have our priority areas, which are to reduce jail recidivism, increase oral health, increase or decrease unintended pregnancies, increase behavioral health access.
Yep. That covers our questions so far.
Terrific. Okay, I'm going to move on to the August cohort expectation. So the first thing that I really want to stress is that these learning cohorts will really be designed with our partners, both through our feedback session and moving forward. Again, we do not want this to come across as a penalty, but rather as an investment in ensuring that our system of care in the region does not lose any access while we make this transition to value-based care. It will be the expectation that each partnering provider will develop a cross-functional team for participation. That doesn't mean that everybody comes to everything, but based on the topics and who should be in the room or participating, that we would not expect it would be a single person who comes and just listens to meet our expectation. As I mentioned, it'll be a mix of in-person and virtual meetings. We are really aware that in the winter, it is hard to move around across the region, as well as when we talk about a cross-functional team, it is highly likely that people could be at many different locations. So we're going to try and have a nice combination, but I would say that it will be important to think about that active participation portion of it. We've mentioned being paid for participation moving forward. Additionally, we wanted to really stress that we're sort of referring to this as the faculty will draw on both local, state, and national expertise to really design both the curriculum and deliver the curriculum. Part of the opportunity here is to really learn from each other. And we saw throughout the plans just a tremendous amount of best practices and emerging practices. And so as we think about how the system cohesively comes together, learning from peers will be an important part. And then it is expected that the August cohorts will be ready to contract with BHT in Q3 of 2019. So I'll pause there and see if there are any August cohort questions.
We have no questions.
Excellent. This just gives you a sense of potential topics, and these are really reflective of some of our observations of the plan. So I'll just give you a moment to glance through those. I think none of these should be surprising to anyone in terms of the kinds of areas of focus we would have. I would also add that while the January cohort is likely to be ready to contract in Q1 of 2019, we do expect some participation in some of this sessions across both cohorts that really aid in ensuring we have a cohesive regional system, and/or I think there are going to be some great sessions that folks would be interested in participating for, even if you have a more developed plan.
I have a question here. If we are ready to contract in Q3, when would the plans need to be submitted, given that BHT would need time to review them?
Yeah, we're still working on the final plan. I would imagine that those plans would be submitted in July, and then it's really August, September, and October that we'd be moving towards contracting for. We feel confident that the learning cohort will prepare partners, so there isn't a bunch of work once the learning cohort is complete to have your plan be done. It's really going to be a building process throughout the 5, 6, 7 month process. Okay, so moving on to our next step. So as I think I've mentioned now 10 times, we're in the process of scheduling our feedback calls. If you have not set in motion getting things scheduled, the best time availability is happening now, and putting together 48 feedback sessions is quite a scheduling logistical challenge. So it would be great if folks can move quickly to get their time scheduled. The probably important part that folks are going to be interested in is really this tie back to the funding models. And at this point, we think that there will be 2 key pieces to it. One, pay for reporting. So are you meeting the milestones you put in place? And then provider incentive measures. And we have not vetted what that model will look like, because that will go through our technical councils in the coming 2 months. So I would really just encourage you to pay attention to our technical council meeting schedule and agendas over the next 2 months. If you're interested in either providing feedback or just hearing the discussion about that, those incentive measures will come to the board in November. So we're expecting those recommendations to be complete by the end of the November technical council meetings. And then the Waiver Finance Committee will be reviewing and recommending our funding approach. And we will start in October with that, with the expectation that we will be ready to take the final recommendation to the board in November. Our team stands really committed to this being a very open and transparent process, and will certainly invite any of our partnering providers to any of the technical councils if they wanted to listen to the feedback or give any comments at the beginning of any of the meetings. We also will make sure that notes and overviews are being posted to our collaborative website on a regular basis. If you're not able to participate in that way, the opportunity to see that information will be there. We offer a public comment period before each of our board meetings. And so if you have things that you would like to have the board focus on, concerns that you're seeing, that's a really excellent time to make sure that they are hearing your feedback. And of course, the BHT staff stands ready at any moment to both have some discussion about where we think we are headed, as well as answer any questions or concerns that you have. It is our expectation that after the November board meeting, that both the January cohort and the August cohort will have a good sense of the dollars that they potentially can earn for both pay for performance and pay for reporting in 2019 and 2020.
So we have one more question in the chat box asking how much time should they plan for the feedback sessions?
We believe that we should be able to get through them in 60 minutes.
I'm gonna unmute the room for anybody to ask questions over the phone, or if you like, you can continue adding your questions to the chat box. We have about 3 minutes left in our time today. You are unmuted.
So we will sit and listen for as long as you have questions. We know that this is a lot. Well, I can't help but brag that there are people actually saying thank you and that we're being super transparent. So we appreciate the kind feedback. It is without a doubt the intent of both the board and the BHT staff to be as clear and concise as we can, both from a process standpoint and a decision-making process. So I'm going to just hang out here for another 5 minutes or so, and if anybody wants to weigh in. Otherwise, that concludes our formal presentation. Thanks, everyone.
We have one question that says, a lot has changed for our individual agencies since we submitted our transformation plan. Is it possible that with clarification in the review meeting that petitioning for the January cohort can be done with relative ease?
I think that is definitely possible. We wanted to leave open that opportunity that it is a clunky template process, and if providers are ready to move quickly through addressing any of the gaps that we see, that would be possible.
And we have a clarification that the team that we refer to for the Spokane tribe is 2 people that are rocking it.
Outstanding. We know who you are, and we see you, and you are doing heck of a good work.
If the August cohorts are meeting their goals with their transformation plan, will there be pay for performance?
There will be pay for performance once you move into the contracting phase. So during the cohort, we would consider that to just be pay for reporting milestones.
So is there a penalty for completing goals before contracting?
I'm not sure I quite understand the question, but our intent would not be to penalize anyone for moving quickly through achievement of any pay for reporting milestones. Okay, we are past 12:30. I'm going to look at Kim and see if there are any final questions for the good of the order. Otherwise, please feel free to email any of us. I am Allison, ALISON, at betterhealthtogether.org. And we will look forward to some further discussion and conversation with everyone. Thank you so much for your active participation in this process. We are super proud of our region and see so much ongoing potential for really good work ahead of us. Thanks, everyone.
Thank you.